might have a few more people trickle in. Thank you everybody for coming. I'm going to talk to you today about our lab's research that has been going on for several years. I'm going to try to give you an overview of our central program of research. The central goals of our lab are to better understand the chronic stages of traumatic brain injury. We focus on three populations: moderate to severe TBI, post-concussion syndrome. Is that all right?
Yeah, somebody was.
You may know. Okay. Moderate severe TBI, I'll talk to you a little bit about that population in a moment. Post-concussion syndrome, which refers to people who have enduring symptoms of a single or multiple concussion. And we also focus on retired CFL players, because all of these groups contend with enduring symptoms of TBI. But our central program of research focuses on moderate to severe, and that's what I'm going to talk to you about today. What we're interested in is identifying modifiable impediments to recovery in order to be able to develop treatments to offset these impediments and improve outcomes, and then to deliver these treatments across Ontario to scale up. So our lab's goals run the gamut from basic research to applied research to knowledge translation. Today, I'm going to talk to you about rethinking moderate to severe traumatic brain injury, and in particular the chronic stages. I'm going to talk to you about the idea of traumatic brain injury as a chronic disorder or a chronic disease. Then I'll talk to you about our research in trying to understand recovery better from the subacute to the chronic stages, identifying obstacles to recovery at the level of the brain and behavior. Particularly, I'm going to focus on disuse as an impediment to recovery and anxiety. Then I'll talk about developing treatments that are tied to these basic research findings, and then I'll talk to you briefly at the end about getting treatments to people all across Ontario and the idea of developing a brain injury center to do so. Okay, so rethinking moderate severe TBI. A little bit of background. Common causes of traumatic brain injury are car accidents as well as assaults, falls, sports injuries. And we know that there's a higher prevalence of TBIs in young adults and males. You don't need to sustain a direct blow. Sorry, I should just say that the most common cause is car accidents. And in this population, we have more young adults and more males that are sustaining injuries. I just want to flag that you don't have to have a direct blow to the head to sustain a traumatic brain injury. So forces, acceleration, deceleration forces that are exerted to the brain, for example, in the case of a belted passenger or driver, can give rise to a traumatic brain injury. Falls is another very common cause of traumatic brain injuries, moderate to severe TBI. And here the predominant population is older adults and children, and the incidence across sex is equal. We generally see two broad types of damage: focal or impact injury. Here I'm referring to contusions to the brain, hemorrhages, hematomas, and then diffuse injury. So here we see axonal injury or shearing that affects the entire brain. So this is damage to the white matter, the parts of the brain cells or neurons that are responsible for connecting one side of the brain to the other, the back to the front, the top to the bottom. So diffuse, the white matter and compromise to the white matter is really what is responsible for the predominant clinical presentation in traumatic brain injury, rather than focal injuries. Leads or microvascular injury is also occurs diffusely throughout the brain. It's something that doesn't get enough attention, but the acceleration, deceleration forces that give rise to widespread axonal injury also cause tiny little bleeds all over the brain. And of course, if the neurons are not able to either to receive nutritional supply from the blood or can't communicate properly with the blood vessels, you have compromised functioning. Edema is another widespread injury. Oh,
Sorry, I have to dial in here.
okay. Do you want me to stop for a moment?
Oh, yeah, just for a second.
I didn't prepare any jokes. I could tell you about my summer holidays if you want.
Please enter your access code followed by...
Can you hear me all right? Great.
To enable audio controls, please enter your audio PIN followed by the pound or hash sign. If you do not have a PIN, just press pound or hash.
Resume? Okay. There is a lot of disability as a result of moderate to severe traumatic brain injury. So when we extrapolate from a study in 2008 on the American population, they found that 1.1% of the national population is contending with disability, chronic disability from moderate to severe TBI. So in Canada, that would amount to 357,000 people, and that's probably an underestimate. So to continue with this idea of traumatic brain injury as a chronic disorder, there's a beautiful paper that came out by Mazel and DeWitt. They pointed out that TBI it's a chronic disease process. It's not a one-time injury that heals the way a broken bone does. We have enduring consequences of traumatic brain injury: cognitive impairment, attention, memory, executive dysfunctioning, etc., emotional dysfunction, depression, anxiety, anger, and these are enduring well past the acute stages of injury and into the months and years post-injury. Personality changes like increased dependence, apathy, a range of motor impairments, including weakness and coordination. And then as a result, and this is all as a result of the significant brain injury people sustain, of course, and as a result of those impairments, we see psychosocial consequences like elevated unemployment, failure to return to school, broken relationships, social isolation, and economic consequences, enormous financial direct and interest, healthcare costs, in large part related to lost wages. So it's interesting to consider the WHO definition of chronic disease, and you can see that if you look at the main criteria, chronic traumatic brain injury fits very neatly into the idea of chronic disease. So it may require a long period of observation, supervision, or care, or is there difficulty reaching the other?
The people dialed in can't hear the audio.
Okay. Do we want to take a step back and try to resolve it?
No, we'll just carry on. I'm not sure what the problem is. I'll have to call the GoToMeeting people and see what's going on.
Okay. So it may require a long period of observation. What's that?
Your entry is not valid.
So why don't we offer them to see the recording so they don't see it?
Yes, we can send them a recording. I'll send them a note.
Send them a note so they'll get to see the recording so they're not just sort of sitting there frustrated.
Okay. So I would say sorry to them, but they won't be able to hear me anyway. Okay, so it may require a long period of observation, supervision, or care, requires special training of the patient for rehabilitation, caused by non-reversible pathological alterations, and permanent. So those four criteria, WHO criteria, clearly map on to what is going on in the chronic stages of traumatic brain injury. So further quote from the Mazel and DeWitt paper, TBI is seen by many as an event. A broken brain is the equivalent of a broken bone. Once fixed, the brain requires no further treatment beyond a relatively brief period of rehab. Implications. Okay, so why am I telling you all this? Why am I trying to drive this point home? There are a lot of implications for the timing and distribution of therapies. Most of our therapies for people with traumatic brain injury, as probably everyone in this room knows, are crammed into the first hours, days, weeks, and early months post-injury. And if you are Half of the people who have insurance, they may be a little bit longer, but they don't, the services very rarely stand out into the many years that people are contending with the chronic stages of traumatic brain injury. So in terms of the content of therapy also isn't focusing on the chronic issues. Research. So we need to focus on the chronic stages of injury. Most research is, again, focused on acute stages of injury. Okay, so let me summarize that first section. Hundreds of thousands of people are living with chronic disability from traumatic brain injury. Talked about rethinking the chronic stages of moderate to severe TBI. I'm not talking about concussion or mild TBI, but moderate to severe TBI as a disease process. Very high economic consequences of chronic TBI. But clinical care and research into these chronic stages of moderate severe TBI is very limited. So the first goal of our research has been to better understand chronic TBI, to understand causes of poor outcomes. And the approach that we use in our lab is to deliver clinical care while we're collecting our data. So I'll tell you now about our central program of research. We've seen over 200 patients with moderate to severe TBI, and we've assessed them longitudinally at 2 months, 5 months, 12 months, 24 months, 2 years, and a few of them out to 3, 4, and 5 years post-injury. And people are at varying stages of these assessments. And all of these people undergo comprehensive neuropsychological assessment, motor testing, and quantitative MRI looking at volumetric measures of the whole brain and its substructures. And we also carry out diffusion tensor imaging and to look at the white matter of the brain, which I was explaining is so essential in TBI. And we are looking at functional connectivity as well, another metric for brain function. And as I was saying, our approach is it's dual purpose. So when we carry out our clinical neuropsychological assessments, for research purposes, we're actually carrying out a clinical assessment. So if we hadn't told the patients they were participating in research, they wouldn't know it. And then we deliver the findings to them clinically. And this has a couple of key benefits. One is that we're able to deliver care to patients, most of whom would otherwise not receive this care, especially in the chronic stages of injury. And also from a research point of view, it gives us excellent retention. So there's another study in the States called the Model Systems Study where they try to track people longitudinally. Their attrition rate is upwards of 70%. Our retention rate is around 70–75%. So it really makes a huge difference. So we have a database that's really unique in the world. Okay, so let me talk to you about this basic, so here's the basic research that we've been doing in trying to understand recovery from moderate to severe TBI. First of all, cognitive recovery is incomplete. That is no surprise to anybody here. So what this figure is showing you is that we looked at a whole bunch of different cognitive and psychomotor functions: memory, attention, visual attention, visuospatial attention, different aspects of memory functioning, and we looked across time from 2 months post-injury to a year post-injury. And that thick black line at the top is estimated pre-injury levels of functioning. And all we're showing on this figure is that at 1 year post-injury, people are ending up well below their estimated pre-injury level on a wide range of functions. But there's kind of a double whammy, and this is what I want to focus on. So not only is there recovery that is incomplete, but there is a prevailing assumption about cognitive recovery, which is that that level of recovery that people reach at 1 year is maintained in the chronic stages of injury. And in fact, it turns out this is an erroneous assumption, and in some we see quite substantive decline. So we looked a few years ago at 29 subjects from 12 to 24 months post-injury, and we used an index called the Reliable Change Index to see whether people were showing clinically meaningful decline from 12 to 24 months post-injury across a range of domains, cognitive domains. And what we found was that 27% of this sample showed substantive declines in 2 or more domains of functioning. And we just recently replicated these findings in 55 patients with moderate to severe TBI, completely non-overlapping, and we found the exact same or very similar findings, with a pretty substantive proportion of people who are not maintaining that cognitive recovery across the board. So they're going up and then they're dropping off in some areas. At the level of the brain, again, the prevailing assumption is that following the resolution of acute events, the brain remains stable. And this is a slice of someone's brain at 5 months post-injury. And this is what we see in that very same slice at 24 months post-injury. But you can see there is expansion of the original lesions. That's gliosis or scar tissue. So surprisingly, the brain is actually changing across time. And I'm going to talk more about that. So here are some curves that are showing you hippocampal volumes across time from 5 months to 12 months to 24 months post-injury. And what you can see is that the right and left hippocampus, so these are structures that are essential for memory functioning, that they are, can you still hear me? That they are shrinking across time from 5 to 12 to 24, and they're shrinking significantly. Here's the corpus callosum. So this is the white matter structure in the brain that connects the right and the left hemisphere. It's a critical structure for our functioning. And once again, you can see this very significant volume loss. These are the papers that speak to this. It's pretty ubiquitous, these findings. So we looked at 56 adults with moderate to severe TBI. We gave them we undertook quantitative MRI at 5 months and 20+ months post-injury. We actually collapsed our 12 and 24-month data. And what we found was very significant volume loss in 54 or 56 of the individuals. And we saw that in multiple structures. This is another study that focuses specifically on the white matter structure using diffusion tensor imaging. And here in 36 people using longitudinal diffusion tensor imaging at 5 and 30 months post-injury here, we saw significant white matter integrity loss. And again, this is really important because you need the white matter integrity for different parts of the brain to talk to one another. So not surprisingly, mood is not faring that well across time. For some people, it's stable, but we see when we looked at when we looked at the number of people who had significant depressive symptoms, so moderate or greater depressive symptoms using the Beck Depression Inventory from 2 months to 5 to 12 to 24 months post-injury, and this is the work of Jennifer Tomajic. What we see is that depression is practically tripling. Actually, it is tripling from 2 months to 24 months post-injury in terms of the number of people with substantive depression. And anxiety, this is Alex Terpstra's data, looks similar. So you can see that, so that horizontal line at the bottom is the base rate of anxiety in the normal population, people without brain injuries. So you can see again, it starts off much higher than the base rates at 2 months post-injury. It's kind of flat across the first year, and it's jumping again in the later, at 24 months plus post-injury. It's almost doubling. Okay, so again, as you move into the chronic stages of injury, you have more and more people who are suffering mood disorders as well. To summarize, after moderate to severe TBI, for many, the early gains in recovery are not maintained into the chronic stages of TBI. Deterioration is observed in brain structure, cognition, and mood. And so, as our next goal, what we wanted to do was to look for modifiable causes of decline. So, barriers to recovery that we could actually treat. Okay, so there are a lot of variables that we can't do anything about after someone's had a brain injury. We can't do anything about their age. We can't do anything about how much education they've already had. And those factors may be influencing what's going on in the chronic stages of injury. But what can we do something about? So one of the studies that we undertook looked at environmental enrichment. So we looked at the relationship, and I'm going to talk more about exactly what environmental enrichment is, but think of it as augmented cognitive, physical, and social stimulation. We focused in particular on cognitive environmental enrichment in this study. And we simply looked at the relationship between self-reported cognitive environmental enrichment at 5 months post-injury and what the hippocampi were doing from 5 months to 28 months post-injury. And what we found was that there was a significant correlation between how much environmental enrichment people were reporting at 5 months and how much hippocampal volume loss they had. So I showed you those curves that there's quite significant hippocampal volume loss, but the more environmental enrichment, the less hippocampal volume loss. So it looks like environmental enrichment may buffer against this hippocampal volume loss. And this is a correlational study, so further research is needed, but that's really an important potential target for intervention to try to offset some of these really deleterious chronic effects we're seeing. That's disuse. So anxiety as a modifiable problem. We're really interested in anxiety because for a variety of reasons, but some recent findings just came out of Baycrest actually, that looked at the relationship between anxiety and mild cognitive impairment and conversion to Alzheimer's disease. And what they found was in the medial temporal lobes, which house the hippocampi, okay, there was a causal relationship between the amount of anxiety and the amount of medial temporal lobe volume loss in amnestic patients who converted to Alzheimer's disease. So strong relationships between anxiety and conversion to amnestic MCI to Alzheimer's disease. Very important because those were causal findings. So we, in a study and this is a study by Alex Terpstra, who's over there, 91 patients with moderate to severe TBI. Alex did some really nice structural equation modeling that allows you to look at causality of relationships rather than correlation. And he looked at anxiety and hippocampal change scores, so the impact of anxiety on change in hippocampal volume and controlling for depression. So to illustrate that here, he's looking at the impact of anxiety on hippocampal volume change from 5 months to 12 months, and then, sorry, that's anxiety at 5 months, and then he looks at anxiety at 12 months on hippocampal volume change or volume loss from 12 to 24 months. And what he found was that higher anxiety was causally related to left hippocampal atrophy. So that's a really important finding because it's, again, another modifiable cause, something that we can actually intervene on to try to offset these losses that we're seeing. Okay, so disuse, to summarize, disuse and anxiety are causes of atrophy in our chronic moderate to severe TBI patients. I say disuse because that's the flip side of environmental enrichment. I forgot to say that, but so our third goal is to develop treatments to treat anxiety and disuse to augment environmental enrichment, and also concurrently treat other symptoms of traumatic brain injury. So now we're moving from our basic research, the last two goals focused on basic, and now we're moving into more applied work, and we're talking about the development of treatments. Okay, so we take a combination therapy approach. There's a lot of data to show that when you combine interventions, when you combine behavioral interventions or behavioral and pharmacological interventions you get a whole that is greater than the sum of the parts. So you get synergistic effects of your interventions. You can also think about vicious and virtuous circles. So in terms of impairments, we know that depression and anxiety contribute to reduced cognition. They also both contribute to reduced volume loss, particularly in the hippocampi, and reduced cognition contributes to increased depression and anxiety. So these are some of the vicious circles. So by taking a combination therapy approach, and you can see how this might help to alleviate all of the different symptoms of TBI. And virtuous circles. So if we can improve cognition, we can improve self-efficacy, which improves mood. These are relationships that are previously demonstrated. Improving mood enhances neurogenesis, which also improves cognition. Okay, so I'm just trying to explain why, some of the reasons why we're particularly interested in this combination therapy approach. So we have the way that we've approached our delivery of interventions is because we're trying to help our patients while we're trying to understand our interventions. We want to make sure that we're delivering therapies, at least some therapies that have known efficacy for the symptoms in the neurological populations. So we take a combination of tried and true therapies. So we include cognitive behavior therapy, which our lab and other groups have demonstrated that there's efficacy for TBI. We use mindful meditation, which has beautiful demonstrated efficacy for neurological populations, and goal management training. So here we're trying to treat anxiety, plus all the other symptoms that we see in TBI, including depression, for example. And we also have a more experimental arm. So our combination therapy comprises both those tried and true clinical treatments and experimental treatments. And the experimental arm, which is focusing on preventing decline in particular and dealing with the disuse, is environmental enrichment. So I'm going to start by telling you about environmental enrichment, and then I'm going to move back to those other tried and true clinical interventions that we use. Environmental enrichment in animals looks kind of like this. So the way that you manipulate environmental enrichment is very straightforward in animals. You have a standard or deprived environment on the left here, which has a few rats or mice, and then you have an enriched environment that has a lot of toys. It has more rats to hang out with, socialize with. They change up the food frequently, so there's a lot of stimulation. Okay, so environmental enrichment is stimulation that is continuously complex, continuously novel, continuously challenging and effortful, intensive, and engaging. And we try to make it enjoyable to maximize engagement. So we've been using for our environmental enrichment an intervention called Brain HQ. It's a little bit like Lumosity, but it's a brain game, but it has a very strong empirical record. And I want to flag something for you. You probably know that brain games have a pretty bad rap right now. Brain games, when it comes to trying to enhance IQ in healthy adults who have no neurological problems, there is very limited efficacy in terms of doing that. There are little pockets where we see some improvements in terms of visuospatial attention, for example. You guys can come and sit down. But this is a very different target here, and it's tied to our own basic research. We're not trying to increase IQ. We're trying to offset. That disuse-mediated atrophy of the hippocampi we saw. So remember, we saw that the people that have less cognitive stimulation have more hippocampal atrophy. So that's our target of environmental enrichment here. And that is well founded in research in terms with brain games. Part of the reason we're very interested in brain games is that They're self-administrable, so they have potential to help us when we're trying to deliver environmental enrichment to people for over the course of many years, right across the province. We need something like this. It also has a lot of, it helps us to achieve many of the active ingredients for environmental enrichment. So for example, with brain games, the brain games can be programmed to continuously change the level of challenge so that you get this continuous increase or continuous challenge that's necessary. And they're rewarding and fun, so that helps with maximizing engagement. Okay. There is a ton of research, particularly in the animal literature, on the benefits of environmental enrichment for brain and behavior. We see increased neurogenesis, some really interesting findings. Animal findings show that physical exercise increases the proliferation of new neurons in the brain, particularly in the hippocampi and in the dentate gyrus in particular. Cognitive environmental enrichment promotes the maintenance or the survival of those new neurons, which otherwise tend to die off, and their integration into existing networks. We see with environmental enrichment angiogenesis, so new vascular supply, and remember I told you that I was talking about how that's compromised in TBI. We see new synapses formed and remodeling of existing synapses. Amyloid, we see reduced amyloid and amyloid precursor protein, which is bad for the brain, and we see that in TBI. There's improved learning and memory, and improved recovery from TBI that we've seen. So it's pretty great, environmental enrichment. Figuring out what works for a particular person is a tall order, because what's stimulating for one person isn't necessarily stimulating for another. So you can send someone into a very enriched environment like a library, but they're not necessarily going to read the books. So I'll come back to that a little bit more later when I talk about, at the end of the talk, when I talk about delivery of environmental enrichment. So Diana Frasca, who's over there, she wrote a paper that talking about the challenges of getting environmental enrichment to people in the chronic stages of TBI. And there are a number of barriers to delivery of this, what we think is a really essential ingredient in in their recovery and in maintenance of recovery. So in terms of direct barriers, there's simply a lack of resources. So, I talked about the fact that so many of our resources are crunched up in the early days and weeks and months, but later on, later on there's a real dearth of resources, like community centers or groups or fitness centers, libraries, therapies, indirect barriers that affect access to environmental enrichment include, for example, a lack of insurance, financial support, social support to enable people to get to places where they can get this environmental enrichment. Okay, so as I say, I'll come back to what we're trying to do to get environmental enrichment out to people in the chronic stages of injury and to get around these barriers that I'm talking about. So now let me spend a couple of minutes on those tried and true therapies I mentioned. So just to recap, we take this combination therapy approach, we deliver the combination of environmental enrichment and tried and true therapies. So goal management training is one of them. Some of you may have heard of this. It's one of the very few interventions that has efficacy for enhancing cognitive functioning in neurological patients. We have real difficulties in the world of neurorehab in coming up with therapies that actually enhance functioning. Okay, so goal management training is a rehabilitation approach for higher order cognitive skills, executive functioning skills. And essentially, it helps us to do a better job of planning and implementing our goals. Even if one doesn't have executive dysfunction, this is beneficial. And in fact, people are starting to deliver goal management training to out in the private sector, for example, and in other populations without brain injury. We use cognitive behavior therapy. This is a problem-solving approach to change unhelpful or undermining thinking and different behaviors. And we really like cognitive behavior therapy because we've demonstrated in previous research that we can deliver cognitive behavior therapy to people. It's a kind of psychotherapy. We can deliver it to people over the telephone. And we found that it was just as effective over the phone in people with quite significant acquired brain injuries as face-to-face therapy was in ameliorating symptoms of emotional distress, depression, anxiety. Okay. Cognitive behavior therapy focuses on the here and now. It's typically time limited, so usually 10 or 11 sessions. It's very skill-based. It's concrete. People tend to respond very well to cognitive behavior therapy. Another treatment that we include is mindfulness meditation. For those of you who were at Research Day last year, or this past Research Day, we did a quick mindfulness meditation. Leslie Rattan and Jennifer Tomajic delivered that. It refers to paying attention in a particular way, on purpose in the present moment and non-judgmentally. You kind of try to watch your thoughts and detach your emotions from your thoughts. You're also regulating your breathing. It has tremendous demonstrated efficacy. We did a review paper a few years ago reviewing the benefits of mindfulness meditation for the brain, and it shows benefits to attentional functioning. It's beneficial for depression, anxiety, stress, physical pain, improves quality of life, and it shows structural and functional brain changes. And these are all relevant to TBI. And one of the really interesting findings in mindfulness meditation is that it actually reduces activation of the amygdala. So the amygdala is a structure in the brain that is involved in rage. And of course, our TBI patients have a lot of difficulty regulating emotions. They have a lot of difficulty with anger management. And mindfulness meditation shows that a key structure in the brain that is responsible for anger and rage is actually less activated after mindfulness meditation. So I know I sound like I have stock in mindfulness meditation, or I sound evangelical about it, but everybody should be engaging in mindfulness meditation, in my humble opinion. Okay, so this is just, you don't have to look at the details of this, but this is how we deliver our combination therapy. So we give people 20 weeks of environmental enrichment, 34 minutes a day, and that runs concurrently with 9 weeks of goal management training, 2 hours per week, and 11 weeks of cognitive behavior therapy and mindfulness. It's pretty intensive, but surprisingly, in our feasibility studies, people stick with it. So we've run several groups now, face-to-face and over the internet. So in our I'm showing you the results with a population of retired CFL players. And we also run this on moderate to severe TBI patients. And you might think of them as a tougher group. You know, if you think about stereotypes of CFL players, you might think that this would be too fluffy for them, touchy-feely. So 5 of 6 of the participants in the group completed the entire very intensive protocol. The attendance for GMT was 100%. We allowed them to make up sessions, so if they missed because they were on vacation, they could make it up. For the CBT part, there wasn't an opportunity to make up sessions, so the attendance was still very high. And the environmental enrichment compliance was low in terms of the number of daily hours and sessions per week that they did. But we weren't on them. It wasn't face-to-face. They had to do it on their own. So we're trying to figure out what we have to do to get people to engage more. And in fact, in an online intervention that we've just embarked on with CFL players, where we're reminding them all the time, they're more compliant. So preliminary findings from that group in terms of the emotional functioning, you can see if you look, these are pre-post findings on a scale that looks at depression, anxiety, and stress, and you can see that this small group shows a pretty substantive decrease in depression, anxiety, and stress. Oh, and what I wanted to say was also they really liked the mindfulness meditation, and I think they were universally skeptical about mindfulness meditation when they started. So the satisfaction survey was great in this group, really positive comments about this very intensive intervention. There's another, the internet-based group that's underway. It's really challenging to deliver therapies online. I'm not going to go into the details here much. We've also delivered the combination therapy to patients face-to-face. We've done a feasibility study that was Banu Sharma's master's study, where we got people to administer brain games to themselves at home. So moderate to severe TBI patients had to do it for 12 weeks, and they did not a bad job with barely any environmental support. They were also able to self-administer a tool to let us know whether there were any adverse symptoms or adverse effects of participating in the environmental enrichment. So what we do need to do, if we're giving people these therapies to do at home, we actually need to know whether we're having any negative impact on them. And it was great to see that this tool that we developed, they actually administered it and we got to themselves and we got useful information from it. I'm giving you now kind of superficial detail, and I'm happy to take questions about all of these interventions afterwards. Kind of as an aside, I just wanted to let you know that we're pretty actively involved, not only in moderate to severe TBI patients, not only the CFL players for whom I just showed you a little bit of data, but also, as I mentioned earlier, people with post-concussion syndrome, so people with enduring symptoms from a single or a couple of concussions. So what we've been doing there in terms of intervention is we've been doing education and support workshops. We've completed 6 so far. These are face-to-face. We've had 100 people participate. There are 2 sessions that we deliver these in. So the whole workshop comprises 2 sessions delivered over the course of 1 month. There was over 70% retention across the 2 sessions. So if you came the first time, you were very likely to come the second time, and really positive responses to that. Okay, so summary, we've been adapting existing interventions for moderate to severe TBI patients. I haven't told you about the adaptations that we did to these interventions because I don't want to bombard you any more than I already am. It's a lot of information I'm giving you. We've assessed face-to-face and internet-based feasibility of our intervention protocol, and we've demonstrated some preliminary feasibility and efficacy. Our next steps are to continue to deliver the intervention and test it, to assess efficacy for cognitive functioning, brain functioning, and offsetting deterioration, and to develop a delivery model to scale up delivery to people. We want to deliver it much more widely. So let me talk to you in the last couple of minutes, and I'll leave time for some questions at the very end about this scaling up. One of the collaborators for this is Elizabeth Rochon, who's in the audience, and Alex Mihalidis, and maybe Tilak will be involved in this too. So we're trying to develop a center for delivering therapies to people in the chronic stages of TBI to address the solutions that I talked about earlier to those clinical challenges of getting therapies, particularly environmental, out to people. So we need an approach that allows us to deliver therapy that's ongoing, that's affordable, that's feasible, and that's accessible to people regardless of their geographic location or physical disabilities. Our treatment approach needs to be customized. The environmental enrichment piece needs to be customized for personal relevance. So we're trying to develop a repertoire of environmental enrichment therapies that would be relevant to anybody to pull out. So therapies like brain games that focus on gardening or how to make tomato sauce, for example. Because we need a big repertoire of therapies that people can use for life and that are relevant, interesting. We're using a teletherapy approach, which resolves our access barriers. We've demonstrated that it works. We're also using an online self-administered approach. Again, this resolves resource challenges and allows us to scale up. I told you about a study we've already done involving self-administered EE. We're using pervasive computing to resolve some of the intensity challenges. What this involves to some extent is, in terms of pervasive computing, is not only the delivery of therapies to people over the computer, like the brain games that they would do maybe half an hour, an hour a day, but we also want to deliver challenges to them all day long. We want iPads on their wall that can discriminate a patient from another family member and that issues challenges that are cognitively stimulating. So we have a lot of different ideas around that. Also developing an anger management bracelet that's the work of Alex and our PhD student Tuck that reads, and actually Jeff is on that committee, that can read electrophysiological symptoms and help to ascertain whether somebody's temper is rising. Again, that's something we can give to people in their homes. I talked to you about the combination therapy. Okay, so in terms of this provincial center, harness our current research to improve outcomes. We're trying to provide cutting-edge clinical care while conducting new research into better treatments. We're using intensified home-based treatments. We're trying to improve outcomes to increase quality of life, reduce family burden, and we're trying to reduce healthcare costs. We're also trying to create a prototype for scaled-up, cost-effective, far-reaching research and treatment that can be replicated elsewhere in Canada and around the globe. So we want to create a template for Ontario that we can hand over to other provinces at the end. Okay, I have a few more slides, but I'm just going to end here so I can take some questions.
Can I make a comment first?
Yes.
That was fabulous. It was the first time that I've actually seen the whole program integrated, and so it made the event really worthwhile. So let me throw something out of left field at you. Have you got any thoughts on the mechanism? I know it's not central to your work, but the mechanism that connects anxiety to a change in volume of the left hippocampus.
Alex, do you want to feel that? Oh, there's a sleep and TBI person that's postulating that it's sleep. There are a few different mechanisms. Do you want to feel that?
Well, my understanding is that stress is most likely to be the culprit there. We know that anxiety and mood problems can dysregulate the HPA axis, and in turn cause elevated levels of stress and sort of creates more of a challenge for people who are facing small stressors or large stressors in regulating their responses. So we also know that stress can increase anxiety, so it could also be a synergistic relationship, which may be why anxiety is playing such a prominent role, is because it's again a cycle that's sort of propagating on itself.
So the very,
So does it correlate with cortisol
cortisol.
measurement?
Yeah. And so one of the things that we're really interested in doing that we're not doing yet is, can you hear me at the back? Okay. Is to measure cortisol levels in patients acutely and later on. And it's not, hello? I think it's, no, we've been actually having some trouble with this mic. It's not that, thank you. It's not that hard to measure cortisol levels, so that's one of the things we need to do.
That's what's good.
Yeah.
So just to follow up on that, I was intrigued about that too, and also the dissociation with depression. Yeah, so in your findings, I think, Alex, you controlled for depression, so anxiety was the major factor.
Right, so we control for depression because there's a lot of data out there showing a correlation between depression and hippocampal volume. We know that depression is bad for the hippocampus. We wanted to partial out the effects of depression and focus exclusively on the causal role of anxiety. We've been looking at our depression data, and it's definitely not having the same impact as anxiety in our population, interestingly. and we don't know why that is yet. But I'm reluctant to comment on the depression findings just yet.
You didn't mention medication as a potential contribution to the treatment?
Yeah, we controlled for medications. We looked at a lot of different factors. We controlled for a lot of different factors, and in our depression data as well.
I was wondering about treating anxiety.
Oh yeah, so I was trying to give you a sense of our kind of orientation in our lab towards treatment, and we are very interested in focusing on very, benign interventions. We're not engaged in pharmacological interventions, but of course, if someone has anxiety, medication is a very logical intervention, and we would expect that that will be effective in terms of helping to alleviate the hippocampal volume loss. And in fact, anxiety in concert with behavioral intervention might provide that synergistic benefit.
Thank you. I noted in your CFL data that one of the comments was better sleep in response to the program. And I'm just wondering what was the nature of changes in sleep, and whether you, Alex, whether you noted a higher incidence of insomnia in that particular group that may have been mitigated through the mindfulness and anxiety reduction.
Did you want to answer that, or do you want me to answer that? I think that
You can, just as.
Yeah, I know you don't have those access to those data. So actually, there aren't good data. You will consider, so Catherine Wiseman-Higgs is our resident expert in TBI and sleep, and you will consider, and Tatiana, and you will consider this egregious, but we really didn't do a very good job of capturing sleep disorders, and we know that's part of the story, and we're trying to do a better job of that now.
Do you want to tell us about some of the issues you've encountered with the internet-based therapies that you're employing, and modifications you've had to make for
Sure.
terrible obstacles and challenges?
Sure. Well, the person that was overseeing it, Dr. Leslie Roseanne, we've had to deliver cognitive behavior therapy to and mindfulness meditation to get her over the trauma of trying to get this off the ground. It was really hard. So in order to I am just kidding, but so in order to deliver therapy across the provinces, we needed approval from the College of Psychologists in the other province that we were dealing with, in British Columbia. They made Leslie register and take an exam to be able to allow us to deliver the therapies. That's the College of Psychologists. They tend to be very tough and by the book, but that's okay. So we got over that hump, and now it's doable.
So it's not technological, your
So
problem?
technological issues are also big. We had been forewarned that we would need an expert, a technology expert in terms of our delivery system present at every session. And there's always some troubleshooting that needs to be carried out when we do our internet-based therapies. So something that we're working on, I mean, that's, given that we're trying to scale up, this is something that needs to be corrected, because it's going to really impede our efforts to deliver therapies really broadly if we have all of these technological problems. I think we will get past them. And the other person that needed some therapy was Brenda, who actually literally had to deliver a device. She had to drive the night before a therapy session some computer equipment to somebody in Hamilton. It was because of a computer malfunction.
I'm wondering if you can do some of your, if it would make sense to do some of the environmental enrichment things not on a computer. So particularly for retired athletes, I noticed that in your, you had one slide with 4 pictures of sort of ideas about what environmental enrichment might be, and one of them was dancing.
Yeah.
And I'm thinking, maybe something for people who are physically oriented individuals, maybe actually going dancing would be as good as a wine game about dancing.
Dancing is particularly great because it combines physical and cognitive enrichment and social. And so we're thinking about other kinds of modalities for other different forms of environmental enrichment than just the computerized ones. I realized something else that's kind of important that I left out was one of the things that we're trying to develop a system of delivery, a fairly elaborate system that is really, for which we're very dependent on Alex and also Babak and maybe Tilak too. Tilak's been involved in some, but not all of our efforts. We're trying to develop a system whereby we call it a hybrid system because we want to continuously monitor all of the patients that we have in our intervention protocols. And we were trying to reach many, many patients with Toronto Rehab as central command. But part of this system involves getting, we don't want to actually look at and keep track of patients every single day because that would really deplete our resources. So part of the delivery system will involve tracking people as they engage in our different interventions and alerts sent back to us only when there's a problem. So when someone hasn't engaged in a long time, or when they engage and they're not showing expected improvements or they're showing deteriorations. Another piece is that we're partnering with local partners in the north because we really want people who are local to be able to go in and check up on patients. So if patients are actually, if we are learning that a patient is, for example, suicidal, we want someone that's local to be able to go in and intervene.
Just one more question. Just wondering if you've thought of or had the opportunity to look at communication partner training and working with significant others in the home to work on some of the environmental enrichment, et cetera.
Elizabeth, I think you've been particularly interested in that aspect of things. We're very interested in the caregivers. We're very interested in support networks. It's a huge piece of this. We just had a CFL player. But by the way, these interventions that we're working on are relevant to the moderate to severe TBI and also, as you can tell, the CFL players. We just had a player almost besiege us to deliver at the very least, education to spouses. Because, especially in the chronic stages where everybody expects patients to be fully recovered or expect things to be getting better and better, or at least maintaining. They wanted us to explain that that's not always the case, that sometimes there are declines, that it's not because the patients are weak or aren't trying. So that's one piece of the caregiver support. But yes, what we're trying to do is set up a system where the patients are receiving their therapies with as little support from other people as possible to keep the resources down. But of course, where family members are willing and able, we want to harness that. Thank you, everybody.